Has anybody heard of osteoporosis? All right, interesting, because no one raised their hands for sarcopenia, but a lot of people seem to know about osteoporosis. It seems like a common condition, although as far as the statistics about how common or the prevalence, not a lot is known because it's often referred to as the silent disease. Has anybody ever heard of the silent disease? Any ideas as to why it gets its name? You may not know that you have it because largely it doesn't come with any symptoms. Some of you, if you do have osteoporosis, you might think, well, I experience pain. How can you tell me that you don't have any symptoms? But often the pain is a side effect of maybe sustaining a fracture from the condition. So the condition itself largely doesn't have any symptoms. So we'll talk a little bit about that as we get into it. Okay, this first slide here, you might not be able to see that, but on the bottom of that left image, it says normal bone, and on the right it says osteoporotic bone. So that image is a cross-section of a bone, okay? The white stuff is your bone, and the black stuff is the little spaces in between your bone, like a bit of a matrix. And you can see on the left, it's a lot more dense, there's a lot more white, as opposed to the right where there's those large black areas, more porous bones and things like that. So if we go to the next slide and we look at the actual definition of what the condition is, it's a condition where your bones become more brittle and likely to fracture because there is a loss of tissue and density of the bone. This loss often occurs when there's a deficit in minerals such as calcium and that they're used at a faster rate than they're replaced, which is sort of similar to what Sophie was talking about. Often when you've got cells that are being replaced, if they're not being replaced at a fast enough rate, that's when you start to get this deterioration happening. This little graph at the bottom here, which we'll have a little look at now, it looks quite similar to the graph that Sophie was showing. So again, on the bottom axis there, you've got age, and on the vertical axis, you've got bone mineral density, your total bone mineral density, okay? So from the time that you're born, roughly that first 30 years is spent developing, growing, and I suppose developing your bone mineral density. And at the top there, where that sort of dotted line is, you have your peak bone mineral density at about 30 years of age. So one of the big factors, which we'll talk again a little bit in the coming slides, is those first 30 years can really shape what you're going to look like later in life. If you're a very active person when you're growing up, you might actually end up with a higher peak bone mass, and then after that sort of peak, you start to get that deterioration happening, that sort of slow decline. Obviously, the higher the peak, the decline is going to sort of end up higher later in life as opposed to if it was a lower peak, if that makes sense. Now, the red line there is the sort of, I guess, the course of bone mineral density that occurs with women, and the blue line is the course that occurs with men. Now, you'll notice at about that sort of 40 to 50 year bracket, you have a bit of a drop off, a bit of a sudden drop off in bone mineral density, and that is a bit of a result from menopause and the hormonal changes that occur with menopause. So as a result, women tend to be more likely to get this condition. It's not to say that men aren't at risk, but that's just the general trend. All right, so just keep that graph in mind as we go through these slides, okay? For women, if I just go back to that slide, around that sort of age of menopause, you get that real sudden, I say sudden loss. It's probably around 2% of your bone mineral density every year for the first few years after menopause. Generally, it can sit at around 1% per year. This is a bit of a summary of risk factors, okay? The big one is age, because it's an age-related condition. People over 50 years of age are the most at risk. That's when you start to sort of get into that decline, and as I spoke about, the hormonal changes that occur during menopause put females at a greater risk. Yeah, and there's that rate, that 2% per year occurs sort of straight after menopause. If I got $1 for every time a client downstairs said to me, "Don't get old," I'd probably be retired. So, but there's certain things here that are sort of unmodifiable. Okay, so you can't sort of get younger. You can feel younger. You can sort of exercise and things like that. But your age, you can't reverse your age at the end of the day. But there are other modifiable things. So if we go to the next point there, calcium and vitamin D levels. Okay, so that's sort of, I guess, referring to your diet, your nutrition, and they're essential for building and maintaining bone tissue. And vitamin D is basically used to absorb calcium. So they're both as important as each other, but they play slightly different roles. Calcium is obviously largely obtained through your diet, things like dairy, but some alternative sources of calcium, because we're in a day and age where there's vegans and things like that. People do have dietary requirements, but things like your leafy greens, you'd be surprised that they contain quite a bit of calcium. Things like kale. Anybody tried kale here before? Any fans of kale? Keep your hand up if you're an actual fan. Oh, good, a couple of people. I was a bit surprised by that. But also things like broccoli and a lot of Asian greens tend to be high in calcium, like bok choy and things like that. Other sources like nuts, like almonds, things like that. Just a couple of alternatives. And as far as vitamin D, what's our main source of vitamin D? The sun, that's right. So you should try and aim for roughly, as a bit of a recommendation or a guideline, about 30 minutes of direct sunlight every day. Obviously, we live in sunny Queensland where in summer, you're not going to walk out at 2 o'clock in the afternoon to get half an hour of sun. You'll end up in hospital probably. But yeah, so you're trying to sort of, obtain that 30 minutes, maybe outside of the peak UV times. Early morning or late afternoon is a good time. All right, the next point there, your medical history. So certain conditions and medications impact your bones as well. I think before I get into any examples, it's important to state that we, as exercise physiologists, we don't specialise in medication. So if you did have any concerns about the medication that you're on or any things like that, you're best talking to your GP or a qualified pharmacist or someone that's educated specifically in that area. But just to touch on some things that can affect your bone health, things like corticosteroids, cortisone injections. So maybe if you've ever had an inflammatory condition, like a bursa or something like that, you might have needed a cortisone injection. Corticosteroids are also used to treat asthma and rheumatoid arthritis and different inflammatory conditions. Having low hormone levels, so if we spoke about menopause and elevated levels of estrogen. Especially if you go through menopause early in life, that's another risk factor. Or if you have low testosterone levels, thyroid conditions, especially if untreated, again, that's got to do with hormones and things like that. Chronic bowel, liver and kidney disease, and certain medications for cancer, epilepsy and depression. And another point that I just added in here is if you've been on certain medications for a very long period of time, some of the side effects of certain medications can actually lower your bone mineral density over the long term. So again, in that case, I would refer you back to your GP to discuss that if you did have any concerns. And that last point there, lifestyle factors. So these ones are all largely modifiable, okay? So low physical activity levels. And you'll probably find that these points up here about your lifestyle not only are risk factors for osteoporosis, but probably for just about every chronic condition out there. You think of diabetes, heart disease, different things like that. Smoking, excessive alcohol intake, and unhealthy weight. And that doesn't just mean being overweight, it can also mean being underweight or having eating disorders and things like that. And there's been some studies, recent studies, that have shown that certain hormones associated with obesity can actually impact the health of your bones as well. Falls and fractures. Okay, so this is a few points, a few sort of statistics, I guess, to scare you more than anything, but also to, I guess, highlight, like I said earlier, this condition doesn't come with symptoms, so you can kind of just dismiss it. If you don't feel bad, you feel like there's nothing to worry about or anything like that. But I guess this just highlights the impact that it can have if left untreated and if it goes on to become quite serious. It's well understood that people that suffer from osteoporosis and the fractures that can come with that report lower levels of independence and a poorer quality of life. So again, some of the statistics around the prevalence, how common is the condition? not quite as well known because it is the silent disease. A lot of people may have it without it being diagnosed, but to give you a bit of an idea, from about 50 years of age, 1 in 3 men and 1 in 3 women and 1 in 5 men will experience a hip, vertebral or forearm fracture at some stage during their life. And obviously, the older you are, the more at risk you would become, because you can think of the associated loss of mobility and function, maybe poorer balance and different things like that that might impact maybe having a fall. This one here, it's a bit of a heavy statistic, but the risk of death is increased tenfold in the first few weeks after having a hip fracture. Did anybody realise how serious a hip fracture could be? I guess to put it in a bit of context, there are some considerations and different factors that affect that statistic. So again, the main one being age. The older you are, if you think of someone in their 90s that breaks their hip, it's going to be a lot more traumatic than someone that's 50. That's a bit of a generalisation, but to give you an idea. The loss of function and also pre-existing conditions, okay? So if you were to have a fall, it might complicate other conditions that pre-exist as well. So vertebral fractures are the most common kind of fracture, and it's estimated that 2/3 go undiagnosed, which is quite a surprise. You'd think if you fractured somewhere in your spine, you'd feel it or you'd go to your doctors, but up to 2/3 can go undiagnosed. And the last point, which is sort of a bit of a follow-up, it's associated with increased mortality and morbidity, back pain, less physical activity and general function, and postural problems. So just to refer to those, the bottom image on this slide, you can see on the far right you've got what would be considered normal posture. If you think of your correct posture, imagine you ran a plumb line from behind your ear. It should pass through the middle of your shoulder, the outside of your hip, and just behind your ankle bone. The point being that you should look nice and upright. If you were standing flat against a wall with your head pushed back, that's sort of considered your ideal posture. But what we know is if you have sustained any fractures, it can lead to that sort of forward bending posture, that kyphotic posture. Not all kyphosis is related to fractures, but most fractures can sort of result in affecting the posture, which can affect your balance and blah, blah, blah. It's a bit of a vicious cycle. So let's talk a little bit about diagnosis. So you might be thinking, oh, this osteoporosis is a bit more serious than I thought. How do I know if I've got it? How can I be tested? Generally speaking, the best way would be to speak with your doctor. Bone mineral density is measured using the DEXA scan. I won't try and pronounce that. I'll be tongue-tied all day long. A DEXA scan. So that's the same thing that Sophie was talking about earlier, which you can look at breaking down your body composition, muscle and fat and water and things like that. But that's what it looks like on the bottom left there. And as far as your bone health or your bone mineral density, you'll be categorised into one of those following. So they use the T-score as the measure. And if it's -1 or above, that would be considered a healthy, normal bone mineral density. And then I guess the lower it is, if it's between -1 and 2.5, it would be considered low, but not quite osteoporosis. So there's another condition called osteopenia, which I guess is a slightly less serious. It's a bit of a precursor for osteoporosis, but it still means that you're not below that threshold, but you're sitting just above it, okay? But yes, and you can be classed as having osteoporosis and severe osteoporosis, which generally means that you've had a history of having a fracture somewhere, and it might slightly affect the treatment that you undergo for that as well. Okay, so what can we do to treat osteoporosis? And I think it's important as well to not look at it as a treatment, but also a prevention. You may have quite healthy bones, but it's not to say that you might not develop it later in life. So think of it from a preventative standpoint as well, if you would. When I was talking about the risk factors, I spoke about modifiable risk factors and unmodifiable risk factors. So if you think of the modifiable risk factors, a lot of them were to do with your lifestyle. So your diet. Maybe you think, oh, look, I probably don't eat, I don't really pay special attention to my diet. Maybe I don't eat enough sort of dairy, or maybe I'm eating too much dairy. Maybe you're a bit unsure about the guidelines around diet. In that case, as Sophie suggested, it would be a good idea to maybe talk to a dietitian, but having maybe your diet looked at and maybe a bit more specialised might be an idea. Quitting smoking, which would be an obvious one in terms of any chronic condition, lung conditions, heart conditions, things like that. Reducing your alcohol intake. And the last one, which is the one that we're most concerned about, because that's what we specialise in, is exercise. Engaging in exercise, and the right kind of exercise, which is what I'll talk about in the next slide. Medication. Medication is another form of treatment for osteoporosis. Again, just to reiterate on the point I made earlier, it's not something that we specialise in. I get a lot of questions about, how common are the side effects with medication? It's not really my area of specialty, but what I can tell you is that it does have it can have a significant impact on improving your bone mineral density. It can come in tablet form or injections. That will be something that your GP would obviously discuss with you and put in place for you. And lastly, early intervention. Obviously, if you think of back to that graph, that sort of slow decline, if you act early before you've been diagnosed, and a lot of people tend to either, if you haven't been to your GP and had a test like that, a lot of people find out that they've got osteoporosis after they've maybe had a fall and had a fracture, and then their doctor might actually go and refer them. So acting early and doing what you can is a very important point, I think. Okay, exercise recommendations. I guess some of the important factors about exercise is it depends on the kind of exercise, the intensity of the exercise, and the dose, which is just how much should you be doing. You might be surprised to know that not all exercise are equally effective at improving your bone mineral density. In fact, studies have shown swimming, cycling, and walking all to be ineffective. Does that surprise anyone? Because a lot of people will probably, you might walk every day and you might think, well, I'll walk for an hour every day, and that's excellent. That's not to say that you shouldn't be doing it, because as we know, that kind of exercise, walking, swimming, it's going to help with your aerobic fitness, it's going to help with your cardiovascular fitness, the health of your heart and your lungs. It's going to probably help reduce fat and keep you at a nice healthy weight, and other cardiometabolic factors. However, prescribing walking in isolation or swimming in isolation, so having that as your only or main form of exercise, has been shown to be insufficient to optimise bone health and can have basically no impact on your bones, which is surprising. So, what should you be doing then? These are the sort of basic guidelines. Now, these guidelines are based on research as well. They're not just sort of thrown out as a bit of a suggestion, but it's stuff that's been proven to work. The type of exercise you should be doing is a combination of resistance exercise, okay, or your weights training, and high impact exercise. So, as far as high impact exercise, that's things like, you might have seen, if you've ever seen any sort of programs on bone health, osteoporosis, you might see people stomping on stairs, walking like side stomping and things like that, jumping. Obviously there's some considerations there. If you were considered to be in the really severe osteoporosis category, doing really high impact exercise might slightly increase your risk of fracture. So that's where us exercise specialists would be able to sort of help you out and tell you what is going to be safe for you. As far as the frequency, 2 sessions a week as a minimum. So just to touch on what Nancy asked before about exercise at home, maybe if you were to come to a clinic like we have, and you might do your 2 sessions a week there, but there's certain things you could be doing at home, provided it's the right kind of specific exercise. Maybe it is certain stomping exercises or jumping exercises. You could perform that at home to complement what you do at an exercise clinic. Generally speaking, the more exercise you do, the more benefit you're likely to get. Having said that, we know rest is important, letting your muscles recover, but 2 sessions a week as a minimum. And as far as the duration of each session, you're looking at about 45 to 60 minutes. And the intensity of the exercise, similar to the treating sarcopenia, you're sort of looking at that progressive increase of resistance. Trampoline, as far as bone mineral density, I would probably tend to say no, because a trampoline's obviously going to absorb a lot of the impact. Depends what you do on it, I guess. If you were doing certain weight exercises and things like that, but the bones only respond to like a jarring, and it's got to be that high impact. So if you're on a trampoline, that's absorbing a lot of the impact. So it's like if you're in a swimming pool, you're way less in water, and so you're not getting that kind of impact and things like that. So I'd argue probably not the best approach. It's important to start from a progressive approach, because if you've never been to a gym, or if you've never lifted a weight or in an exercise kind of setting, you're not maybe going to have the support of the skeleton. The muscles may not quite provide that foundation of strength to support your skeleton. So it's important then that you start light with a focus on good technique, and that way you can progressively build it up. But eventually you want to be working at a high enough intensity that's going to put enough strain on the bones. One other point, I guess, where it says other there, you want to target all the major muscle groups, but there's also an emphasis on balance, okay? If you're doing an exercise program to treat osteoporosis, you should be doing some form of balance exercise as well. Obviously, if you were to have a fall, you're going to be at more risk to fracture something. So doing balance-specific exercises to help reduce that risk is pretty imperative. I think I had a bit of a study here to call on. In one study that I looked at, clients participated in a program that followed these basic guidelines, okay? 2 sessions a week for, an hour each session. And over the course of about 24 weeks, okay, which is just a bit short of 6 months, they had improvements of about 1 to 3% in their bone mineral density. And that doesn't sound like much. And to think that's nearly 6 months of exercise. So I guess the important thing to note is that exercise, it's a fantastic way to treat conditions, but it's not a quick fix solution. It takes time, it takes energy, and it takes commitment as well. It's got to be consistent, but definitely you can see improvements. And personally, I've had clients that have maybe been on a program for around 12 months that have seen up to 6% increases. So you can get pretty significant improvements. Everyone's going to be a little bit different, but I think it's important to note that it is a process. In that case, there's obviously going to be certain considerations. If you have had a replacement in the hip, you have really severe osteoporosis in the hips, you probably would be looking to avoid some of the high impact exercise. But that's not to say that exercise is not going to help. There'd be other forms of exercise, like you might stick to more of a strict, just resistance-based exercise program. So yeah, there's definitely considerations, and in that case, we wouldn't prescribe them for you personally. Yeah. One of the programs we offer in the exercise clinic downstairs is called our Stomp Out Osteoporosis program. It's a 10-week program, and it is obviously an exercise-based program and education. So you have fortnightly topics that we speak about, and you'll probably find that we go into a little bit more depth, because if I'm speaking for about a half an hour just today on a bit of everything, we're speaking about half an hour a fortnight on more specific topics. It's 2 sessions a week. The group size is about 10 to 14 participants, and you've got 2 accredited exercise physiologists sort of looking after you, making sure that you're doing things correctly, making sure you're doing things safely. We also look at testing balance and strength. The 30-second sit-to-stand test that you did just before, that might be one of the tests in the assessment. As we know, your bone mineral density, it takes a while to improve. So we do other tests because the program's only for 10 weeks. We're looking at other measures like your balance, things that might reduce your risk of having a fall or having a fracture. And as far as the expectations, you all have similar exercise prescriptions, but you all have your own program as well. So if you do have special considerations, if you've had a hip replacement or whatever it might be, that's something we definitely take into consideration. Hopefully you can read the other points up there. But I think it's important to note as well that you don't have to have osteoporosis to be able to do this program. You might just be thinking, oh, well, I'd like to know more about it and know what I can do to prevent maybe getting it. anyone can do the program. You don't have to have experience in a gym either. Maybe you might be thinking, oh look, I don't think I've ever been to a gym before, so don't let that put you off. We assume that everyone coming in, it's their first time walking into an exercise clinic. So we're there to help you out and make sure you'll feel nice and comfortable. And it starts next week on Tuesday. So if you want any information, feel free to drop down to the clinic. I think there's a few flyers here as well. There are limited spots in the programs. So if you think that it's something that you'd really like to do, make sure you inquire nice and early, because it could well fill up and you'll have to wait till the next intake, which will just carry on after the 10 weeks finishes.